This program is brought to you by Emory University.
All right. Well, good morning, everyone, and thank you for joining us for Heart and Vascular Grand Rounds this morning. We are lucky to have Dr. Rebecca Hahn joining us for Grand Rounds, and my privilege to introduce her today. So I will try to be brief because I know she's going to have a great talk for us. Um, I could spend probably the full hour just talking about her accolades and her accomplishments. So I'll try to be as succinct as I can. So she started her medical training and graduated from Washington University in St. Louis, and then completed all of her training in New York at the Cornell campus for the New York Hospital, and then has been spent her career in New York, first at Cornell, and then ultimately getting recruited to Columbia to direct their interventional echo program, and is now professor of medicine there, as well as the chief scientific officer of the CRF core lab. So, authored countless articles, book chapters. She's on 4 different writing committees for the ASE. Been a national PI for a structural heart trial. So, it is would be very easy to say she's certainly the most influential voice and person in the structural interventional echo space, and does a lot, selection committees and those types of things for structural heart trials. So glad she's going to be talking to us today, kind of give us the landscape of tricuspid regurgitation and where we're going.
Thank you so much, Patrick. That was a very generous introduction. So hopefully I can meet the expectations of the group. But tricuspid regurgitation obviously has become a fairly hot topic. We now have 2 approved devices. And so I'd like to just go over pretty much what we've learned over the course of the last decade or so. Those are my disclosures. And so we'll examine the current understanding, but also look at the strengths and limitations of imaging and how imaging has allowed us to learn more about the disease, and then review the role of surgery and transcatheter devices. And what we know about tricuspid regurgitation and its prevalence is that it increases with age, as does all valvular heart disease. But as you can see from the Framingham study, it was the first time we really learned that there's about a 4-to-1 prevalence of the disease in females versus males once they reach their 70s. And so when we look at the prevalence in other studies, we see that although relatively low in the Framingham study, that more studies are understanding the disease process, and it's actually a higher prevalence. As a matter of fact, this is a very recent study that's never been published but was presented at ACC that shows that the prevalence of TR is indeed the highest in the age group that we're talking about. So in the 7th and 8th decades, and so again, about 7% of the population in patients being referred for echoes may actually have significant tricuspid regurgitation. And we also know that of the various other diseases, that tricuspid regurgitation carries perhaps the highest all-cause and cardiovascular mortality. And this is a study looking at the UK Biobank, showing again a hazard for all-cause and cardiovascular mortality of almost threefold. And so this is a disease process that deserves our attention. Now, there are a lot of early misconceptions about tricuspid regurgitation. This study coming from Nina Brunwald looked at rheumatic heart disease and showed that if you repair the mitral valve, then post-op, the PA pressures come down to the normal or near normal levels. And so her suggestion was that you could ignore the tricuspid valve when you're doing your mitral valve repair. And so that was our first misconception, that TR will resolve following left heart surgery. But in this quote from the 1800s, the tricuspid valve is designed to become incompetent. And so indeed, when you look at the studies of mitral valve surgery, whether you have repaired the tricuspid valve or not, that those patients still progress in the severity of their disease. And so you can see in the study from Jose Navia that in patients without tricuspid valve concomitant repair, then 31% of the patients initially have no preoperative TR, and 62% with moderate. And those patients begin to progress over time. And the same thing occurs with those patients that have already had a repair. And so this is not a disease that remains still. This is a disease that seems to progress. And so we have a number of different factors that have been shown to predict progression after surgical repair, which include imaging and echocardiographic parameters like advanced tethering, reduced LV and RV function, but also clinical factors like female gender and chronic atrial fibrillation. Those are all factors that we know predict progression even in the natural history studies. And then obviously kidney disease and chronic obstructive pulmonary disease. We also know that there are surgical predictors, such as the type of repair that you do. And so there are a number of things that we could learn from our surgical colleagues about who are the patients that end up progressing. And this is a study from the CT Surgery Network trial that showed that patients that had MR recurrence and those patients with permanent pacemakers or defibrillators were the patients at highest risk for progressing to greater than moderate disease after repair. And so we need to understand that rate of progression as well as who's going to progress. And in natural history studies, we can also look to the predictors of rapid progression. And so this is a study coming out of Jerome Bax's lab by Edgar Prahadi, who looked and found that these parameters determined rapid progression, and this is progression in less than or equal to 1.2 years, and so very rapid. And you can see that the presence of defibrillators is there. Any presence of regurgitation, so more than none or trace, will predict progression. So again, it's just a progressive disease. But also those patients that had intervening left-sided valve surgery had one of the higher risks as well. And so on multivariate analysis, you can see the predictors here and of the more rapid progression, and those are predictors of obviously increased mortality. In a large population-based study, the population attributable fractions, when looking at the initial risk factors for progression, including the ones that we've already mentioned, age, female sex, pulmonary artery pressures, atrial fibrillation, pacemakers, as well as left atrial enlargement, so high left atrial pressures, heart failure, and valvular heart disease. The ones that contributed to, in a general population, to TR progression were the ones on the left side of this central illustration, which are pulmonary artery pressure of greater than or equal to 36 millimeters of mercury. So almost a normal pressure. These are just mildly elevated pressures. Left atrial enlargement, I think a surrogate for high left atrial pressures. Age greater than or equal to 60, and atrial fibrillation. And in the absence of the four risk factors, progression occurred in only about 3% of patients. Otherwise, progression occurred at much higher rates. This has been confirmed by other studies that the rate of progression is indeed an important factor in outcomes. But this study shows that it's not just TR and the TR severity at baseline, but also RV dysfunction as well as the pulmonary pressures. Now, when you look at this newest study that's just come out of 1,800 patients and followed over time, so at least a median of 2.3 years, they found that about 18% of patients progressed, and the predictors are the usual suspects. So age and chronic kidney disease, New York Heart Association class RV dilatation. But I think one of the more remarkable things that they showed was that there was a 38% of patients regressed. And so there is something about tricuspid regurgitation that may be treatable and may allow us to then treat our patients not only with surgical or transcatheter device therapies, but perhaps medical therapy. So 38, more than progression, there were a significant number that at after the time of diagnosis with greater than or equal to moderate tricuspid regurgitation, they regressed. progressed. And so this is a patient population, I think, that deserves study. And as you can see, that if you regress, you have no hazard for increased cardiovascular mortality compared to those patients who were non-progressors, who stayed stable at moderate. And that indeed, those patients with progression, 18% of those patients, had a significantly worse survival, particularly if they had progressed to massive or torrential disease. So again, some validation for the increased grading scheme, which we'll cover later as well. So one of the other things we learned early on was that there was a graded response to mortality. So the increase in tricuspid regurgitation was associated with increasing mortality. And this was true whether it was in a heart failure population, mitral regurgitation population, aortic stenosis or aortic regurgitation population. So there's a graded response to tricuspid regurgitation with particularly concomitant left-sided disease. So there was a misconception that TR was just an innocent bystander of those disease processes, similar to what was suggested by Nina Brunwald, that if perhaps you treated that primary disease, TR would go away and not be a predictor of outcomes. But this is a meta-analysis of 70 studies that showed that even when adjusting for RV dysfunction or atrial fibrillation, mitral regurgitation, LV dysfunction, or pulmonary pressures, that tricuspid regurgitation remained a predictor of all-cause mortality. So it's not an innocent bystander in and of itself. As a matter of fact, in a long-term, this is a 20-year follow-up by the National Echocardiography Database of Australia, they showed that if at the incident echo, if you had mild tricuspid regurgitation, then your risk for all-cause mortality by 18 years was 1.29, so 30% higher. And so this is not a benign disease. It is a progressive disease, and it is one associated with mortality. So can we understand more by understanding anatomy and pathophysiology? I think so. If you look at the tricuspid annulus anatomy, then we understand that it's D-shaped. So it's actually stabilized by the septum. So that's the flat part of the annulus. And then obviously out the lateral side is more free wall. There are multiple crisscrossing muscle bands at the base from the RV myocardium directly to the base of the leaflet. So there is going to be an effect of RV dilatation on the tricuspid valve. And then the annulus itself is virtual. There's really no fibrous tissue. And if you ran your finger across from the right atrium to the right ventricle, you wouldn't be able to feel the annulus. And in addition, like the mitral valve, this is a saddle-shaped, oh, I guess it's not playing. This is a saddle-shaped structure with 20% change in area, perimeter, and diameters during the cardiac cycle, and it also has a hinge-like motion. So remember that it is tethered at the septum. And so just the shortening of the right ventricle and this hinge-like motion of the annulus allows for passive transfer of the blood in diastole into the right ventricle. And so this is an extraordinarily efficient way of transferring blood flow, but you'll see there are other efficiencies of the right ventricle as well. When you look at the histology of the annulus, as I described before, you're not going to feel fibrous tissue. It goes directly from right atrial myocardium to right ventricular myocardium. And the space between the two muscle heads differs around the circumference of the annulus, with the inferior site being having a greater distance, so less myocardium forming the support structure of the annulus inferiorly and a little bit laterally. The other thing we know is that the dynamics of the annulus are important, and that once you lose those dynamics, such as in atrial fibrillation, then the blunted tricuspid annular area change and larger right atrial volume become independent predictors of tricuspid regurgitation. The efficiency goes beyond that of just the hinge-like motion of the annulus and the contraction of the annulus. It also extends to the vena cava. And so you can see here that when you look at the flow pattern of a normal patient from the superior and inferior vena cava, the orientation of these two structures allows for a natural helical flow pattern to occur, and that creates energy that then can move the blood forward across the tricuspid annulus. annulus, and that when with the aging process we lose that orientation, which we all know that we've changed the orientation of the IVC in particular toward the septum, then we begin to lose that vortex formation and lose efficiency of blood flow. The three-dimensional nature of the annulus is really best described using imaging modalities like three-dimensional echo or CMR. And we've learned that just a single dimension, which the guidelines use of four-chamber view and diastole, 4 centimeters or 21 millimeters per meter squared, being consistent with progression of disease and dilatation of the annulus, is just a silly concept because this is a three-dimensional structure. And depending on exactly how you're imaging that four-chamber view, you can change the diameter significantly. And so I think that we really should get away from thinking about the annulus as just a linear dimension in a four-chamber view, but really understand the three-dimensional nature of not only the contraction pattern, but also the changes in size. And so you can see here the significant changes that were recorded by Karima Adisha when she did her three-dimensional study, showing that diastole, mid-systole, end systole, and late diastole all have different varying sizes. So you can see again during one cardiac cycle the changes in those dimensions, but also that when you index for body size and look at the differences between men and women, that women end up having larger annular areas, particularly area and versus perimeter and diameters compared to men. Now, why should there be a sex variation in annular dimensions? I mean, I think part of it, and we're exploring this through the UK Biobank, part of this may be related to the need to be able to increase the diameter of the annulus and blood flow during pregnancy. But there also turns out to be anatomic differences in the annulus that may support the progression of the disease in females versus males. And so in this pathologic study, you can see that males have more myocardial bundles, which may be absent in females. So remember, those myocardial bundles come from the atria and the ventricle. Males have more dense elastic fibers. Females may have more organized collagen fibers to begin with, but there may be more fibroblasts in males that may begin to accommodate for any changes in hemodynamics. And therefore, males in general seem to have enhanced hemodynamic pliability of the valves and an ability to regulate the annular size and contraction versus females, given their relatively low density of elastic fibers, which may predispose them to stretch. Now, we also know that the leaflets are highly variable, and that this was a slide from 2018 that I'd made on three-dimensional imaging, that you can see multiple leaflets. And the tricuspid valve has always been described as being highly variable, and you can see that on three-dimensional echo, particularly from the transgastric views and then on 3D rendering, that we can see those leaflets. In addition, color Doppler helps to show that they're either commissures or scallops between those multiple leaflets, and that's what we ended up using to try and differentiate the complex anatomy of the tricuspid valve. So this is almost 580 patients from 4 different sites, 2 in the US, 2 in Germany, showing and roughly the prevalence of each of these was roughly the same in each of the countries, but 54% have regular 3-leaflet morphology, so a type 1. The rest have a combination of the ones that you see here, with the most common being the 2-scalloped or the 2-leaflet posterior valve, the 3B morphology. And so I've had a lot of people say that, oh, this doesn't exist, you're making up the whole thing. But when you go to the ex vivo images of the University of Minnesota Visible Heart Lab, they actually have examples of all these on their website. So this is a typical tri-leaflet. It has a pacemaker on the right atrium. This is a typical tri-leaflet valve that you can see here. This is one that we would have called bi-leaflet. Now you can see some indentations of the leaflet, but primarily one long scallop. This would be a 3A, so we we have a indentation or a true leaflet. So typically an indentation of the anterior leaflet that we would call a 3A. This is the 3B with the two posterior leaflets. Really easy to see on echo and on the visible heart lab. This is a type 4. These are type 4s. These are just multiple scallops everywhere. And we've seen them. We just did a procedure on one on Thursday, and where we had 6 leaflets, and so or 6 scallops. So it's hard to know whether they're true commissures and leaflets versus just indentations that end up causing difficulty sometimes with TEER devices. And this has been most recently validated, the complexity of the valve in a pathologic study. We're also engaging the Padua pathology lab in order to with Christina Basso to try and do the same thing that this lab did, looking at 107, I think, patients. But we're have a few more than that, and we'll be able to hopefully describe the complex nature of these valves. So the tricuspid attachments to the right ventricle are very unique. There's one consistent and typically large anterior papillary muscle that supplies chordae to typically the anterior and the posterior leaflet. Every now and then it also supplies chordae to the septal leaflet. The septal, there are multiple posterior chordae typically, depending on how many leaflets or scallops. We frequently will see 2. Sometimes just 1, but often 2. This happens to be a double-headed single posterior papillary muscle that I'm showing on the moving image. And then the septal leaflet has possibly the most number of cords, and many of them are directly attached to the septum without identifiable papillary muscles. And so this is a classic example of what we end up seeing, which is that the anterior portion of the septal leaflet attaches directly to the septum. The posterior portion of the septal leaflet ends up having more small papillary muscles that you can end up identifying. But the other complexity of the valve, of the chordal attachment, is that there are frequently these little crossbars that end up obviously limiting the way that you can move your device within the ventricle, and therefore have to be considered when positioning both TTVRs and TEER devices. Now, the RV is also heavily trabeculated, and because of that, the U-shaped structure of the inflow to the outflow is actually benefits from the marked trabeculation, since the blood flow almost none of the blood flow will enter the actual apex in a normal patient, and that you can really see from these 4D flow images. So here's the apex, very little blood flow, and in a normal patient, it'll just be this U-shaped flow going straight out of the pulmonary artery. But the interesting thing is that just a little bit of left ventricular disease, and you begin to get more discoordinated, and you can see these vortices here, discoordinated flow patterns of the right ventricle. And these are even worse when you look at patients, and hopefully you'll be able to see it. It's having a lot of trouble. When you look at the flow patterns of patients with pulmonary hypertension. We're going to move on because those movies, I think, we're having some difficulty playing. But with the pulmonary hypertension, you end up seeing a lot more blood flow because of RV dilatation entering into these trabeculated portions of the RV, but also even worse vortex formation within the pulmonary artery itself. And so these are the types of things that will reduce forward stroke volume. Now, the new classification of tricuspid regurgitation is the one that's shown here. This happens to be in the TVARC manuscript, but has been adopted by other guidelines, particularly in Europe. And in it, we've taken out the pacemaker-related disease out of the primary category, since indeed it can't really be primary when you have a lead in place, and the pacemaker itself may cause not only leaflet abnormalities, but may perforate the papillary muscles or be entangled or adherent to the subvalvular apparatus. In large population studies, the pacemakers of the primary diseases ended up being the largest category. And so as its own category, we also know we have studies now that show that it has adverse outcomes. And so we have primary pacemaker related and two types of secondary disease, similar to the mitral valve. That's the ventricular and the atrial secondary disease. So unfortunately, a lot of movies in this and causing trouble, obviously, with the playing. But you can see here examples of primary disease. So Epstein's or congenital disease, endocarditis, flail leaflet from biopsy. This was a transplant patient, and this is a carcinoid patient. These are all primary disease processes. And we know that those patients with primary disease end up having a slightly better prognosis than those patients with secondary disease. So this is just one of many studies that shows that. And then when we look at pacemaker-related disease, you can have two different types. One is the pacemaker is actually causing the regurgitation, so impingement of the leaflet subvalvular apparatus or the papillary muscles, or you can have just an incidental pacemaker. But whether or not it's incidental or related, tricuspid regurgitation in the setting of a pacemaker is associated with adverse outcomes. So these are just examples of the various different ways that you can be affected by the pacemaker, and imaging obviously plays a key role. We've just this is now in press. This is a state-of-the-art review of management of pacemakers in severe tricuspid regurgitation. And the one etiology that I hadn't really thought about, but is thrombus. And so the last one here in image I shows a thrombus on a leadless pacemaker. And so pulmonary hypertension related to thromboembolic disease may be another etiology of pacemaker-related tricuspid regurgitation. Now, the frequency of pacemaker-related disease in the literature is just all over the map. And the reason for that is really the difficulty in making the diagnosis, the actual primary diagnosis of lead associated TR. And in that setting, most studies are simply based on worsening of the TR grade following lead implantation instead of actual visualization. So there's a lot of variability. And then, of course, the amount of progression also varies among the studies. Is it severe? Is it up one grade, et cetera? But what we do know is from, again, the NEDA database. So this is National Echocardiography Database of Australia, showing again that pacemakers are associated with a nearly twofold increase in the probability of progression of the disease, and that mortality is associated with moderate or greater TR. And so in my mind, those patients with pacemakers need to really be followed up very closely to extract a lead that is less than 2 years old, has very low complication rates. To extract a lead that's 10 years old is associated with a lot of complication rates, including avulsion of the valve. And so these are patients that need to be followed closely for progression of their disease. And when they get to moderate, if the lead is relatively young, it's possible to extract that lead and then place either a coronary sinus lead, something not across the valve, or a leadless pacemaker. Now, the pathophysiology of atrial versus ventricular secondary disease was described as early as 2012 by Jan Topilsky, and he called it idiopathic secondary TR, but this is atrial functional disease or atrial secondary disease, and it's secondary to annular and atrial dilatation. This we know is related typically to atrial fibrillation, but also to heart failure with preserved ejection fraction. And in the setting of a markedly dilated annulus, there's not enough leaflet for coaptation. The secondary disease associated with ventricular dilatation or ventricular secondary disease occurs in the setting, and he called it pulmonary hypertension, functional TR, but we now know is ventricular secondary disease, is associated with dilatation of the mid-RV, so it can be from primary cardiomyopathy, pulmonary hypertension, either arterial or post-capillary. And in that setting, the RV free wall, which is the most sensitive but also prone to dilatation, ends up causing the papillary and large anterior papillary muscle to be pulled out laterally. And when in doing so, then pulls out the anterior and posterior leaflets, causing failure of coaptation within the ventricle and tethering of the leaflets. And so this was described also by three-dimensional echo by Denise Moraro, where she showed that all secondary diseases have annular dilatation and right atrial dilatation, but the ones with pulmonary hypertension or left heart disease ended up having mid-ventricular dilatation of the RV, a more spherical shape to the RV, and therefore tethering of the leaflets, which is the little green volumes, and that the atrial functional disease had the largest amount of annular and atrial dilatation and preservation of the conical shape of the RV. So I'm going to skip some of the movies since they're not playing well, but when you're looking at atrial secondary disease, this is a classic example of a patient we might see with normal LV, completely normal LV function, and mild dilatation of the left atrium, but massive dilatation of the right atrium and annulus, therefore causing not significant mitral regurgitation, but significant tricuspid regurgitation. And I think we've all seen those patients. And it turns out that in the setting of atrial fibrillation, when you look at the relationship between the two annuli and ventricular function, that the patient with normal LV function and atrial fibrillation, such as HFpEF, so heart failure with preserved ejection fraction, they will dilate the tricuspid annulus greater than the mitral annulus, like the patient I just showed you. Whereas those patients who have LV systolic dysfunction and atrial fibrillation will dilate both annuli relatively equally. And so this is the construct for why atrial fibrillation may lead to tricuspid regurgitation. Now, the atrial secondary TR has many different um, definitions. And so this is the one that comes from the ACC-AHA guidelines that was based on the Jan Topilsky study that I just showed you. Atrial fibrillation, LV function that's normal, and pulmonary artery pressures that are also within a relatively normal range, so less than 50, so just mild, with no left-sided disease and a normal pairing tricuspid valve. And when you use that criteria, then you can see that ventricular and atrial secondary disease have very different outcomes. And so there's a twofold significantly higher in 1-year combined endpoint in ventricular secondary disease versus atrial, and that when you looked at the multivariable predictors of outcomes, it is TR in those patients with atrial secondary disease, and it's TR and RV function in those patients with ventricular secondary disease, which makes total sense. But maybe one of the reasons why, this is one of the reasons why we ended up picking a lot of patients with atrial secondary disease to go into the trials and perhaps saw a lower mortality than we expected. So again, while severe TR is the only parameter independently associated with prognosis, in atrial secondary disease, you have to consider the RV size and function in those patients with ventricular secondary disease. This outcomes difference was also confirmed in this study that used a cluster approach to define a more morphologic a secondary TR, which was tenting height, mid-ventricular dimensions, and then also a ventricular LV ejection fraction of greater than 50%. And so in these patients, both conservatively treated and in those with TTVR, we end up seeing a significant difference in outcomes. Now, a more recent study looking at the distribution of severe secondary tricuspid regurgitation, so different types of ventricular secondary disease as well as atrial secondary disease, showed exactly what all the other studies have shown, which was a better survival in atrial and a worse survival in ventricular. But when you subcategorized the ventricular disease, this has also been proven. Pulmonary hypertension has the worst outcomes. Next to that is left ventricular cardiac disease, so left-sided cardiac disease, including left valvular disease, and then any patient with significant RV dysfunction. We've attempted, and this is from the PCR focus group on tricuspid valve, but the same chart is in the TVARC document. So we coordinated efforts to try and define atrial versus ventricular secondary phenotypes, and using echocardiography and these criteria based on the literature, we were able to come up with criteria that might define those two different categories. And also Denise Moraro defined the at-risk patient, which obviously includes the usual unusual elderly patients and female sex atrial fibrillation or flutter, and tricuspid annular dilatation, but also included those patients who don't have atrial fibrillation, such as those with heart failure with preserved ejection fraction. And so in this study, looking at the difference in outcomes associated with TR in patients with reduced ejection fraction or preserved ejection fraction, clearly those patients with preserved ejection fraction, the TR, now plays a role in outcomes. So we do believe that HFpEF and tricuspid regurgitation is a type of phenotype or perhaps late stage of heart failure with preserved ejection fraction. A new state-of-the-art article has just been accepted for publication, and Jagan will describe this kind of phenotype of HFpEF and TR. What we've learned also is that if we try to categorize our individual patients into atrial versus ventricular secondary disease, we have a really hard time because the majority of them are mixed. But one of the ways that we have is to look at RV systolic function. And so the issue really is how to look at systolic, how to look at RV function. We know that there's three different types of contraction. There's the bellows effect because of the ventricular septum forms a stable surface against which the circumferential fibers contract. And then there's traction on the free wall. So with motion of the LV will take along with it the RV, and then there's contraction of the longitudinal fibers. And so how to describe each of those motions has been something that we've been attempting to define. We traditionally have just looked at longitudinal function, so that's TAPSE and S prime, free wall strain. Those are all really mainly longitudinal function. Fractional area change gets at a little bit of the circumferential shortening, and 3D volumes and ejection fraction may be the key here, since it will look at all functions of the right ventricle. We've attempted in TVARC to come up with definitions of mild, moderate, and severe dysfunction. This has not been done in any of the guidelines. And so outcomes, we hope this will stimulate research in looking at the outcomes of these various cutoffs to try and determine really who has severe dysfunctions. And since in our guidelines, we should not be intervening on those patients with severe RV dysfunction, yet we've never defined that. The one other metric that we like to use these days is RVPA coupling. We know that this may be one of the more robust ways of measuring function of the RV since it's very sensitive to afterload. Remember again that the RV has to pump the entire stroke volume that the left ventricle pumps into the pulmonary circulation and the left atrium because the mitral valve is closed in systole, and therefore it is very sensitive to afterload. These are some of the non-invasive measures of RVPA coupling that have been studied in a variety of different cardiovascular disease processes, but most recently in tricuspid regurgitation. And the two studies that are in the boxes there are studies specifically in the TR patient population, but this is a study that looked at using TAPSE over PASP, whether using echo estimates of PASP or invasive PASP. And it turns out, of course, that invasive PA pressures in the setting of severe tricuspid regurgitation may be more accurate and have a better predictive ability for determining outcomes. And so we would still use non-invasive, complete non-invasive TAPSE over PASP as one of our metrics since it has a pretty good predictive ability. But if you have an invasive measure of PA pressure, obviously you can improve on that outcome. Because we often don't. This is again a beautiful study coming out of Italy, Denise Muraro's lab, looking at another metric which has been looked at before, which uses echo but does not need to measure PASP. And this is based on three-dimensional echo measuring the forward stroke volume of the RV divided by the end systolic volume. And this again has been validated in other studies. And in looking at that as a metric of RVPA coupling, she showed that it had the greatest prediction of outcomes. And so you see the AUC for stroke volume over end systolic volume compared to the other metrics of RVPA coupling, which were also pretty good, but obviously this was slightly better. So we do feel that you can still measure completely non-invasively, either by the estimated PASP or by using three-dimensional echo and stroke volume over end systolic volume. Remember that, again, the PASP inaccuracy is likely related to the right atrial estimates, which we don't have good estimates on echocardiography. And this editorial that we wrote with Catherine Otto was just to show that as you have a decrease in RA compliance and this V-wave cutoff sign, you're just not going to be able to estimate accurately the PA pressures. And that was confirmed in this study that, again, looked at invasive TAPSE over PASP, but showed in the bottom corner here that those patients with echocardiographic estimates of 3, 8, or 15 were completely off and could not at all measure right atrial pressure. So we don't have good measures of right atrial pressure. Our core lab is taken to just using a generic 8 because there's just no way for us to know whether it's 30 or 3. And so we do need better measures, and we're investigating those in our lab. The other thing to learn is that there's a lot of diastolic interaction. And so as you have the flattening of the septum with massive dilatation of the right ventricle, that ventricular interaction and interdependence comes into play. And so as you flatten the septum, you now have reduced LV filling. And this is why many of our patients present with shortness of breath. The Heracles study was an attempt to redefine those ventricular interactions by looking both at invasive measures as well as CMR, and they indeed showed that with after reduction of tricuspid regurgitation, that you could return the diastolic function of the ventricle, and so there's an opposite change in RV volume and LV volume. You increase LV volume, decrease RV volume, but remember, as you increase LV volume and sphericity, you will increase wall strain and stress. And that is typically why we believe, and this comes from the Triluminate FDA packet, that there is, and you can see in the bottom rows here, an increase in BNP, not infrequently following TTVR or TTVI. Again, I showed this already, so I'll keep going. So the guidelines, where are we? And I only have a few minutes here, but the guidelines are not very clear about medical therapy. The European guidelines have chosen not to give any class of recommendation to any therapy. The US guidelines will give a 2A to both diuretic and to the treatment of the primary disease process, which could include atrial fibrillation and control of rhythm. The European guidelines have this last bullet here, which is pretty important because they have had a lot of 4 different approved CE marked devices for much longer than the US guidelines. But obviously, now that we have 2 devices approved by the FDA ourselves, I think the guidelines will likely change. Now, we know that it's a late presentation of this disease process because the clinical presentation is so protean, and the late symptoms may be associated with aging, like bloating and increased abdominal girth, some edema, etc. But these are all signs of low cardiac output. And as you get fluid retention manifested by jugular venous distension, etc., you decrease the systolic reserve and have low cardiac output, resulting in exercise intolerance, dyspnea, and fatigue for the reasons that I already showed you. And then you increase the risk of atrial or ventricular arrhythmias, as well as cardiorenal and cardiohepatic syndromes. These are very late stage findings, but these are findings that we're seeing in almost all of our patients that present to us for intervention. And so we hope that at some point we'll get to the point where the time to intervene is really when we begin to notice an increase in diuretic need or unresponsiveness to their original diuresis. But instead, what we're doing is intervening when they become unresponsive to diuretics, and this really deserves further study in this population. We've attempted to outline what should be done, the escalation of diuretics and the types of diuretics. You could start with any type, to tell you the truth. It doesn't have to be a loop diuretic, but to escalate in order to treat the congestive symptoms. Now, the treatments of heart failure with reduced ejection fraction, we believe, obviously will also affect TR. We know it is true for the mitral clip procedure. This is the European study. It's a registry that shows that if you improve or have a less baseline with no change of TR, that you'll have better long-term outcomes. This is a 3-year study. And this is the study by Stassen looking at the reduction in tricuspid regurgitation associated with CRT. And finally, the studies with atrial fibrillation are also quite powerful, showing that if you rhythm control, whether or not it's spontaneous rhythm control or active restoration of rhythm of sinus rhythm, then those patients will have a remodeling of their chambers and reduction in AV valve regurgitation. What about pulmonary hypertension? Well, we don't have any good studies showing that treatment of pulmonary arterial hypertension will indeed affect outcomes. But we have this expert opinion poll that was taken. I thought it was really interesting. And in it, they have all these different parameters on echo, and they asked which ones were the most important for clinicians that were treating patients with pulmonary hypertension to respond to increase medications in response to. And you can see the tricuspid regurgitation is right up near the top. So we do think that it is a good marker in those patients with pulmonary arterial hypertension, and that they do deserve therapy. We also, this has also been accepted for publication, will come out pretty soon, but it's an approach to management of those patients with pacemaker lead. But I've already given you some of my insights into that. So the goals of directed medical therapy are to reduce the volume overload and symptoms of congestion, but to treat heart failure, reduced ejection fraction, heart failure with preserved ejection fraction, any left-sided valve disease, pulmonary artery hypertension, and then rhythm control. Now, what about intervention? Well, the US guidelines only have one indication, class 1 indication for intervention, and that's at the time of left heart surgery. So isolated tricuspid valve surgery is not performed very often, and is often performed too late. So these are 2 studies that show that the mortality is 9 to 10% in hospital, that major complications occur in 30% of the patients, and it's the patients that are presenting late and likely the cause of this high mortality because we're operating too late. In the more recent study on contemporary surgical practices, those patients with isolated tricuspid valve surgery, again, still have a 7% mortality rate. Remember that if you take out those patients with endocarditis, those are probably more like the patients that we end up seeing for transcatheter device therapy, and the mortality remains very, very high. There's also a lot of practice variability in using the guidelines to intervene on tricuspid regurgitation. So it's clear that we operate too little, but is operation the answer? This was an article that for a long time, I tried to ignore. I really didn't want to listen to it because my belief was that intervening was going to help with mortality. And indeed, this study showed that after adjusting for immortal time bias, that there was no benefit in these patients that we're treating now, no benefit to surgery. And so I don't think that we should have been too surprised about the outcomes of the Triluminate trial, given that study and given the patient population that were currently treated. But the beauty of the trials that have been performed is that we now have 2 FDA-approved devices, the TEER device, the TriClip, and the Evoke device. And so the questions for all of us are, who are the appropriate patients and what anatomy is suitable, and can we improve outcomes? And various algorithms have been designed as to try and determine which patients, as far as classification of disease, might be more appropriate for one versus the other. And all of those factors may affect the choice. But I want to just point out the patient population. So sorry, these numbers look so small, but I'll review them in just a second. This is a review that's currently in press. where we've compared the BRIGHT, which is the post-market registry in Europe, with the triluminate tier versus control, and then the TriSend data that we have so far on the early patients, both the control and the treatment group. And you can see that there's a lot of differences. So in TriSend 2, which was the Evoke versus the tier devices, those patients tended to be older. They were more female. There was obviously higher New York Heart Association class 3 and 4 prevalence. They had more renal dysfunction. They ended up having lower ejection fractions in the TriSend group. They had a greater percent of prior CIEDs. Again, CIEDs with TR are going to predict outcomes, and then had lower KCCQ scores. Anytime you start with lower KCCQ scores, you have a greater ability to improve, right? And then more heart failure hospitalizations in the prior year. So in some, the TriSend patients versus the Triluminate patients were sicker, and probably had more advanced disease. And so the patients that we do end up seeing, and I'm sorry if this is not showing well, but end up being those with massive and torrential, which is why we designed the increased grading scheme, in order to try and figure out whether or not, and this has been adopted, by the way, by European guidelines, but whether or not those patients with torrential disease would have the same outcomes as those patients with, let's say, just severe. And it turns out that in natural history studies, a lot of studies have now come up showing that indeed there's another grade or multiple grades beyond severe, and that when you look at either just vena contracta diameters or quantitative regurgitant orifice area, there is almost a continuous hazard associated with more and more and larger and larger orifices, regurgitant orifices. And so this has also been shown in the studies coming out of the TTVI, either registries or trials, where we know that the ability to get down either one grade or down to moderate or more, moderate or less, depends highly on where you start. That if you have torrential, you're much less likely to get down to moderate or less tricuspid regurgitation. That this ends up being important for outcomes. So this is the study showing that, again, when you have responders defined as a 2-grade reduction, or at least a 1-grade reduction without pulmonary hypertension, that if you're a responder, you have good outcomes. If you're a non-responder, you do not. So the goal here is that procedural success of 2+ TR or less, all of us would prefer less, may be essential in determining who gets which procedure. And so the PCR working group has come up with favorable, feasible, and unfavorable anatomy. This is just my take on it. There's a couple of additions from the original publication, but this is for the leaflet approximation device, and these are some of the literature that supports that. In addition, these are the favorable, feasible, and unfavorable anatomy for annuloplasty devices, noting that, again, ventricular secondary disease with tethering of the leaflets, which really have a ventricular problem and not as much an annular problem, may not benefit as much from an annuloplasty device. And again, lots of issues with dehiscence because there is no fibrous annulus, and then obviously with the type of patients that you end up choosing. And then for the orthotopic replacement devices, obviously a lot fewer unfavorable anatomy. The main exclusion was the size. So they're only making devices up to a certain size. The 56 millimeter Evoke is not yet approved by the FDA, but also the RV function. So this is a device that takes away all tricuspid regurgitation, and in doing so ends up increasing the effective afterload, therefore putting a lot of stress on the RV. So we do believe that RV function, and why defining what severe is, and the inability to remodel is so important in this disease process, remembering that we also have problems with leaflet thrombosis and therefore possible durability, and other issues of bleeding. So can we improve outcomes? Well, this is the TriValve registry that used propensity propensity matched medical treatment group saying that, yes, we should be able to improve survival. So improve overall survival, you can see in the medically treated group is down in the 60 to 70% range at 1 year, and improved to the survival of 80% in those patients treated with TTVI. Other studies have shown, and this is a meta-analysis, that we can definitely expect the patients to feel better. So New York Heart Association class and 6-minute walk distance. So functionally, they may also get better as the TR is reduced. But this is the meta-analysis by Anna Sanino that suggested, again, that the 1-year mortality on meta-analysis of multiple trials should be down in a very sick patient population, down to 25% versus the 35 to 40% that has been previously reported. So the TRISCEND breakthrough, I'll just say that it was approved. It was the first device approved, but the indications were to improve health status. They made no claims to improve mortality or heart failure hospitalization, but the FDA approved it because the safety and effectiveness endpoints, so safety obviously a little bit lower than for the TEER device, but efficacy significantly higher for the replacement devices, that the safety efficacy endpoints had been met, and that in the limited cohort, this is all from the FDA, there were trends for mortality, functional and quality of life metrics, and heart failure hospitalizations in favor of the device. And so that's one of the reasons why it was approved so early. Now, those were not shown in the TRILUMINATE trial, and yet they did show significant benefit in function and in quality of life, in KCCQ. They couldn't show as much of a change in a 6-minute walk distance. But the FDA did approve the TriClip in April 2nd. And so we now have 2 devices. And again, this is that report that that's about to come out, where we will show you all the data behind the rates of, for instance, single leaflet device attachment for the TEER device, residual TR, so significant residual, moderate TR or greater, and then lower but not trivial bleeding risk with this device, but with the TTVR device, it's a greater risk of thrombosis, prosthesis, pacemaker implantation, and of course bleeding. And so our take on what you might consider for device choice is just a huge list, including all those factors that I've talked to you about before. And remember that the full cohort is yet to be presented for the EVOKE trial. We'll present that in October. And the TriClip device, obviously a recently approved, suggesting that, of course, that we need multiple tools in the toolbox with a number of knowledge gaps remaining that still need to be answered. Thanks for your attention.
Well, thank you. That was fantastic. So certainly a very comprehensive review there. So I guess we just have a few minutes, and if anyone has any questions, go ahead and put them in the chat. I'm going to go ahead and start us off. I know you kind of talked about it at the end there, and kind of what do we do and what devices do we choose. I will tell you that our strong preference here at Emory has been to go with the replacement device, just because of that reduction, like you talk about, in the amount of TR, and just it seems like the improvement in symptoms is just amplified over what we've seen in TEER, for these patients. And I'm curious, I know that there's a lot of considerations, but do you have a sense, at your own center, what you guys prefer and how you decide?
Yeah, that is a loaded question. Yeah, I mean, we do believe that getting the tricuspid regurgitation down to mild is our goal, mild or less. And you're right, 100% right. The EVOKE device is easier to implant. We can put it in almost under 30 minutes pretty routinely. So a short procedure for our patients, and therefore, lower risk of esophageal injury, et cetera. I mean, there's just a lot of advantages to that. But we do have to remember that we don't have long-term durability information about the TTVRs yet. All of them we would like to have on anticoagulation. So patients who have, for instance, perhaps a contraindication to anticoagulation, you might want to reconsider a TTVR. In addition, we've been thinking twice about those patients with pacemakers because we end up jailing those pacemakers. And what we've learned from our EP colleagues is that they claim that we're going to kill people with that, but that those patients who have a high risk for infection, so those patients that have multiple leads or who have already had an infection and a replacement of a pacemaker, those patients are at extraordinary risk for repeat infections of the pacemaker. And if you cannot extract the pacing lead, even if it's a pocket infection, everything comes out, then those patients end up having a very high morbidity mortality rate. And so we do kind of consider again whether or not pacemakers might be a very a light indication for a TEER device. In addition, we don't really know about RV. We've had a few patients, not many, that have had acute afterload mismatch and have ended up being in the hospital much longer than we expected. Now, the beauty of the right ventricle, it seems to always recover. It seems not always, not always. So very, very early on, we put one in a patient we definitely shouldn't have, but it does just ends up taking time. The RV is extraordinarily plastic and has this amazing recoverability. And so we don't actually have any good metrics of that ability to recover. But there may end up being patients, for instance, maybe it'll end up being RVPA coupling and the existence of pulmonary hypertension, where you might want to just have a little bit of a watch out for completely eliminating tricuspid regurgitation. But I think, I think that's why we're ending up seeing some mortality, heart failure, hospitalization, all the labs going in the correct direction. I mean, the FDA SSED was just amazing because it's the first time some of us had seen the device, despite the fact, seen the data, despite the fact that, we're leading some of the trials. That's probably why we're seeing the signals, is we've taken the TR down to nothing. So I agree with you that it's going to be it's going to be quite a decision-making process because we now have both those devices.
Yeah, I think I would agree. We've seen the same kind of recoverability in the RV function, where you might have someone that gets a little bit soft for 24 to 72 hours, but
Yeah.
incredibly they're able to come off the inotropes and recover very, very well. So
Yeah. It takes us about 5 to 7 days. Like normally they're like, oh, they're home the next, not the next day, but like within a couple of
yeah,
days. Yeah, but if they have RV problems, it'll take them about a week.
yeah. So I guess my only other question, and this is another loaded question here, would be, we've all of these patients, it seems like we're treating that are end stage, right? They're end stage renal disease. They're developing liver dysfunction, and where do we go? How do we find that new threshold? Because it seems like the threshold needs to be lowered,
Yeah.
right, for
Yeah.
our where we decide to intervene, and how do we get there, and what are going to be some of those
Yeah.
to do that?
Such a great question. I mean, I do believe that we should intervene at this point at severe, right? So we don't have we know that moderate over time obviously still has a mortality signal. And when you're using PISA, EROA, studies have shown that the cutoff for mortality is going to be somewhere around 30 millimeters squared. But that is, most of those studies were uncorrected PISA. So they actually represent much bigger regurgitant orifices than 30 millimeters squared. And so, the trials are, it's just like the TAVR trials, right? You start with extreme and then you work your way down. And we're working our way down to moderate aortic stenosis, obviously now, and we'll do the same for tricuspid. But for now, it's severe or greater. And our hope is that we get to them at severe. Like I would just be happy if we got to them at severe instead of having, 20%, 30% massive torrential, which is what the trials have. And so I think it's earlier diagnosis diagnosis by echo. It's an awareness of the risk factors for progression of disease, which we now have a number of them, including age, female gender, pacemakers, etc. And these are all factors that I think once we build it into the clinicians' minds, they will end up following those patients more closely, detecting when they get to severe earlier before they have RV dysfunction, and then our outcomes will be extraordinarily good, particularly since we have transcatheter devices.
Yeah, great. We have one question in the chat here, and that is um, so how do you choose anticoagulation, DOACs versus Coumadin in our replacement patients? And then how do you screen for the presence of valve thrombosis? Do you do it solely on echo, or are you screening them with CT as well?
Yeah, so right now in the early phases, most of our patients are also getting a follow-up CT, but not all. And certainly a trigger will be if the echo shows an increase in gradient, or because it's the right side of the heart and it's a near field valve for us on transthoracic, we can actually see the thrombus. And so when we see a leaflet immobility and or thrombus, then and an increasing gradient, then that's what it is, and we start anticoagulating. We don't even wait for the CT. And so those are what if a patient has come in on a DOAC, we will typically go ahead and restart that. But once we see thrombus, we'll escalate and put them on Coumadin, and then bring them back. And there are just some patients who are, unfortunately can't take anticoagulation, and so it's a rare patient that will put on like a dual platelet or something like that. But most of them will be fully anticoagulated. And
Okay.
90% of our patients come in an AFib. So
Right.
so they have an indication for anticoagulation.
It's always disappointing. Someone comes in, they've got a Watchman, and then you put the TTVR, and then they got to restart the anticoagulation.
Yeah, right.
Okay, so one last question here from Dr. Mehta. So thank you for your fantastic presentation. Based on your experience, if you were to do echoes on pregnant patients in the third trimester, do we
Yeah.
know whether moderate TR is predictive for future outcomes?
Yeah, we don't know. I mean, such a good question. So my theory, and the one that we're trying to prove now with the UK Biobank, we've just uncovered their little code to get the data out. It's been 6 months. We couldn't figure out how to get the data out of the UK Biobank. But in any case, we figured it out. But my theory had been that it was related to parity. Because when you look at the AFib data, it turns out that the prevalence of AFib, which is greater in women in the older age group, was related to parity. And so that makes total sense, because now they've had to stretch and come back and stretch and come back during pregnancy, and they just couldn't recover fully. And so we do believe, we think it's going to be related to that in part, and whether or not, and no one has studied pregnant patients during pregnancy, except one study back in the 80s showed that you definitely get TR when you didn't have it at baseline during pregnancy. And this is purely related on RV size, right? Just an increase in volume and stroke volume. So I don't know whether it's predictive. I think it's a great study to do. I think if we prove that parity is indeed related to the 4-to-1 prevalence of the disease in females by the time they're 70, that may be a good next step to try and target which patients may be more prone to progression or persistence of their TR.
Well, thank you so much. That was just excellent, and we certainly appreciate you taking the time. We know you're busy. Sounds like have your hands in just about every tricuspid regurgitation trial or study there is. So thank you for your expertise. And if no one has any other questions, then we'll go ahead and finish up.
The preceding program is copyrighted by Emory University.